talk about these issues, and really the folks who are on the front line to provide a much more detailed and in-depth discussion about this. So we're pleased today to have the chairs of both the Senate and Assembly Alcoholism and Substance Abuse Committees, along with state and national healthcare experts on opioid addiction treatment as part of today's discussion. I'd like now to introduce Leah Kaufman, who's the manager for National Treatment Quality Initiatives from Shatterproof, which is working with the New York State in the development of a rating system for addiction treatment programs. And she'll kick off our forum. A more complete bio on Leah and today's participants is included with your materials, but following Leah's remarks, we'll then have a reactor panel who will provide their perspectives on measures to address the opioid epidemic and ways to improve the treatment landscape. I won't go, in the interest of time, I won't go through who's all on the panel. You've seen it in your materials and who's up here, but with that, before we get started, I would like to thank the HPA staff for their hard work in putting together today's forum. Should there be anything that you need during the course of today's conversation, please don't hesitate to ask or inform one of the HPA staff. And with that, I'd like to ask Leah to get us started. So Leah.
Great. Thank you so much, Eric. As Eric said, I'm manager of National Treatment Quality Initiatives at Shatterproof. We'll be talking today about a 2-year pilot that New York State is participating in. I joined Shatterproof from the National Committee for Quality Assurance, where I manage payer-provider partnerships and initiatives related to coordinated care models. So we're going to be looking at the current challenges in use of evidence-based best practices in the delivery of substance use disorder treatment, from addressing stigma to inconsistent measurement practices across payers and states, to complex utilization management practices and other regulatory barriers that pose a challenge to delivery of high-quality, effective treatment. But first, a little about Shatterproof. Shatterproof's a national nonprofit dedicated to ending the devastation the disease of addiction causes families. We're focused on ending the stigma of addiction and ensuring treatment in America is based upon proven research. We advocate for federal and state policy, payer reform, and provider ratings, as well as providing public education through family and workplace programs. You can see our 4 key domains of work on this slide. Payment reform, treatment capacity, ending stigma, and I'll highlight a bit of our regulatory work, but then we'll focus on the ratings pilot. Shatterproof has successfully advocated for policy change at the federal level and in 15 states, broadening access to naloxone, improving prescribing practices, and increasing addiction treatment resources. So today we're talking about a rating system, but why a rating system? Unfortunately, while we know that addiction can be managed similarly to other chronic diseases, use of evidence-based best practices varies widely across the addiction treatment fields. And as a consumer, you're facing the dual hurdle of both understanding what does it mean to receive high-quality treatment, and then trying to weed out the higher quality providers from those that might be delivering care that's not so great. If we look at the history of healthcare ratings, rating systems have played an important role in creating transparency and providing accessible, digestible information to the public that can be used to guide treatment decisions. We have rating systems in a number of other healthcare and commercial sectors. So many of you may be familiar with CMS's Nursing Home Compare. There's also the Leapfrog's hospital rating system. And unfortunately, there's no current system, especially a centralized one, that exists for addiction treatment. There's some of the literature on the slides about the effectiveness of rating systems. I know we're limited on time, but in general, we see that rating systems have a really big impact both on providers and consumers when it comes to driving quality improvement and steering consumer choice. I wanted to start by, before we get into the rating system and what that's measuring, just touching high level on Shatterproof's national principles of care, which really act as a foundation upon which we built this pilot. These are core components of high quality addiction treatment. These measures, we're looking at measures 2 through 8 for the purposes of the pilot. Measure 1 is not within the scope of the pilot because it's looking at screening in a general healthcare setting. In general, treatment should always be individualized, feedback informed, and encompassing of all of these 8 principles. Principle 1 looks at routine screenings in every medical setting. So with other chronic diseases like diabetes, routine screening is effective in preventing, reducing, treating, and sustaining recovery. Principle number 2 focuses on ensuring treatment considers the unique social, mental, biological, and environmental needs of each patient, and then ensuring there are frequent check-ins and adjustments to treatment as the patient progresses. 3 looks at fast access to treatment. Addiction alters brain chemistry. Brain circuits associated with motivation, inhibition, and stress tolerance are often severely affected in individuals with SUD. Thus, periods of motivational readiness, rarely sustained, and rapid access to care is critical. 4 focuses on disease management. So while some individuals may need a period of intense detoxification or residential care to stabilize cravings and critical health problems, that is not always appropriate for all patients. Sustained engagement and long-term treatment is best accomplished in a local outpatient setting where the clinician can continue to monitor and adapt treatment as needed. Principle 5 focuses on coordinated care for every illness. So this looks at the importance of clinicians considering mental and physical health conditions that may impact treatment and connecting patients to those services. 6 ensures that behavioral health care is delivered by legitimate providers. 7 looks at medication-assisted treatment. And not all people with an SUD do require medication, and there are not medications available for all substance use disorders, but when appropriately prescribed and monitored, medications have been shown to improve outcomes and reduce overdose. And then finally, Principle 8 looks at recovery support services. So ensuring that an individual's social determinants of health are addressed. They're connected to things like housing and employment problems, and there's attention paid to improving family and social relationships that might have been damaged. So with that, we'll tell you a little bit about the rating system project. We actually started earlier this year, February. New York signed on to the pilot. The end goal of this pilot, which runs through April of next year, is to produce a web-based platform. It will have 4 portals. So there'll be a portal for people seeking care to locate providers. There will be a provider portal for those who want to view their quality ratings to help target quality improvement efforts or locate referral partners. There will be a payer portal, this is both commercial and public, and they can use to identify high-performing providers, develop centers of excellence, and then finally, states will have a portal to better target technical assistance dollars. In terms of what is feeding these ratings and what's going to be integrated into that final ratings dashboard, there are 3 different data sources. First, there's a provider survey we'll be administering from August through October, consumer experience surveys, and then insurance claims will be integrated. In addition to New York, we are Massachusetts, Louisiana, Delaware, and West Virginia are participating in this pilot. It's majority funded by Robert Wood Johnson Foundation and the Laura and John Arnold, Arnold Ventures, and by a coalition of 6 national health insurers. There we go. Pilot sites include residential outpatient and intensive outpatient programs that are licensed, certified, or otherwise approved by states to provide substance use disorder treatment. We're using SAMHSA's treatment locator and then identifying sites that might not be included in that to be included as well. So rating system measures, I won't spend a lot of time on this. We do have a full document that includes the rating system measures that went to public comment with our National Quality Forum process earlier this year. Again, there are 3 data sources. For the claims-based measures, we're looking at 4 measures that will gauge factors such as continuity of care after residential treatment and use of MAT. The provider measures, the consumer experience measures include 7 measures as well as a crowdsourced component where patient narrative information can be included. We're looking at consumer experiences related to access, shared decision-making, family support, and their overall rating of a program. The treatment program survey, which again will be an online portal providers will address, runs from August to October. This will look at a number of factors, and there is overlap in the 3 data sources. Use of evidence-based assessment tools, how they handle aspects of care like coordination with physical and medical health providers. And then after public comment, we did add a new measure that will capture, we heard a lot of feedbacks that pointed to wanting to capture factors outside of a program's control. So we added a new measure that will identify factors such as lack of access to technology, and this information won't be public, but it will be used, fed back in those provider and payer portals to help guide ongoing technical assistance and QI efforts. So looking at the timeline, right now, so we launched in New York in February. We've had numerous meetings throughout the state with providers and have rolled out provider roundtables, which are monthly meetings that we touch on different topics. Right now, we have a provider roundtable focusing on the treatment program survey, and we're getting provider feedback to ensure that those measures are feasible and easy to pull data on. The next big milestone is the launch of the treatment program portal in August. And then in Q4, after the treatment program survey has been answered and the consumer experience survey deployed, our research analytics contractor, RTI, will analyze the data from those 3 sources through Q1. And before going public, we will have about a 1-month provider preview period. They'll be able to go in and view ratings, ensure accuracy, and contest anything that they disagree with. And then in April, we will be launching the platform. It will be live for the public to use. And so the one I wanted to point out, the most important thing, I think, and I think Rob agrees with me on this, is that we don't want to create a system that's penalizing providers. I think this is very much about a rising tide mentality and ensuring that we set a floor on quality and provide opportunities to identify gaps for providers, connect them with technical assistance resources, and help them understand how they're performing in relation to their peers. So New York, as a pilot state, is in a very unique position where they can help build this rating system and ensure that it's fair and accurate and that we're measuring the right things before we do scale the rating system nationwide. And with that, I will turn it over to Eric.
Great. Thanks, Leah. So we're like way ahead of schedule this morning, which is great. So we can really jump into conversation. But I know, Senator Harkin, you've got a busy session day today, and we appreciate your willingness to come here. I thought before we jump into the discussion, perhaps turn it over to you if you had any perspectives or thoughts that you wanted to share with the panel or the audience, knowing that you're short on time this morning.
Absolutely, and first of all, thank you and New York Health Plans for gathering everybody today. These types of forums are invaluable because in a crisis, everybody needs to work together and to share best practices in all aspects of this crisis is tremendously important. And Leah, thank you for that. So I'm going to give you just a 30-second overview, and then I apologize. I have to chair a committee meeting in a couple minutes of alcoholism and substance abuse. So it is timely, but
I should have brought them here this morning.
That's right. We should have, because a lot of what we're doing today relates to what we're talking about. But briefly, this has we recognize right off the bat, it's a crisis. We need all hands on deck. The governor, Oasis, they've been tremendous on the front lines of this. We work very closely with our colleagues in the Assembly, Linda Rosenthal, the treatment providers, the parents, the insurance industry. In fact, many of you were very helpful during the budget process in helping us write the Article 7 language on the transition plan or the soft handoff. So far everybody's been stepping up to the plate, and we're asking everybody to do more. We're asking obviously the insurance companies to do more, the treatment providers to do more, the medical community to do more, patient advocates, the public, and the state itself to do more. So it's been a very busy session for us. Started with the budget when we pushed treatment before prior authorization from 14 days to 28 days. We reduced the amount of copays for outpatient visits down to 1 copay. We passed Stevens Law. We passed a law pertaining to folks with Narcan prescriptions getting caught up in medication screens when they applied for life insurance. Today we're taking up legislation that has to do with expanding Good Samaritan laws for public accommodations like restaurants and bars. We have legislation that will ask the medical community, and it's just identical to a law that's been in place in New Jersey, to counsel patients before they're given an opioid and what the alternatives are and what the risks are. And a lot of folks do it, a lot of folks don't do it. And I have personal experience from my own family with my daughter where that was not done. So it's working in New Jersey, and we're working with the medical community to work on language that they feel is appropriate. And we're not trying to ram any of these things down anyone's throat because we realize we're partners and we want to work collaboratively with everybody. I think we've been doing a good job of that. Joelle Foskett, our legislative director, is here. I know she's met with many of you and will continue to. Greg Meyer, chief of staff. So we really view this as a team effort and a partnership, and we're just glad to be part of the team. And we look forward to keep moving the ball down the road to make substantial changes and improvements. And we're not ending when session ends. We're going to be touring the state later this summer, having a series of hearings and meetings on what the gaps in the systems are, what we can do more in terms of harm reduction, prevention, education. So we're going to be very active on this, and we look forward to continuing to work with all of you in the coming months. Thanks so much.
Thank you, Senator, and again, thank you for your work during the budget, particularly around the provision around care coordination. It was obviously something that our industry thought was important to ensure that folks get those warm handoffs that you talk about. We look forward to your ongoing leadership on this issue. So as we jump into the remainder of the discussion, I wanted to kick it off to the panelists, and Rob, we'll start with you. And given the issues that Leah has outlined here, and I think we're looking for everybody's reaction to the approach that Leah's outlined, the importance of what Leah has talked about, and really wanted to just get some perspective from folks as we start the conversation. So Rob?
Sure, thank you. Good morning, everybody. So, as Leah pointed out, New York is one of the pilot states. They didn't just pick us, we asked to be part of this. So to be clear, we asked to be part of what we believe is the best effort to date to try to create a rating system. And part of why we're doing that is we believe in shadowproof, we believe in Gary Mandel and Leah and her colleagues. But we also felt it was incredibly important for this work to produce something that measures the right things. And so that's why we're involved. We believe strongly in it. I've made the comment because we've been meeting regularly, as Leah knows. I think she's learning Albany quite well. But this is not easy. If it was, it would have already been done. So, and I know a lot of, well, the timeline's ambitious, whatever. If you don't set timelines and you don't start to do work that nobody else has done, because maybe it isn't so easy, you'll figure it out. We have confidence in Shatterproof and why it was established, and in Gary and Leah, that we will figure this out. But we'll figure it out by doing it. And it is important. And why is it important? It's important for us to know where our providers are at on meeting the markers that we consider priorities and important. It's important for families and people seeking help to have a better sense of which providers would be the right ones for them to go to. Part of this, and we've worked a lot with insurers, there are folks in this state who are accessing treatment in other locations. I won't say where. They tend to be sunnier though, I won't say that. That is really suboptimal care, and we waste a lot of money. And what they're good at is getting good Google analytics and being high in search engines and not necessarily good in any kind of good care. And they're charging you guys, by the way, exorbitant amounts of money because it's out of network. So this kind of system will help with that as well. It will help us all. And as Leah said, it's not meant to be punitive. It'll assist our providers in figuring out where they measure up with their own colleagues. But so, you know, we're bought into this work. It is important. Just a couple other comments though on Leah's presentation. Completely agree on disease management versus 28 days. And to be clear, I have to say this because I say it everywhere I go. There's no mandate in New York state law for 28 days of treatment. What there is a mandate in New York state law is that you get immediate access to care, no prior authorization. You need to notify the insurer of an admission within 48 hours. There needs to be regular interaction. The statute says periodic interaction. What the 28 days, well, that'll be in January, but it's 14 at this point, is concurrent stay, utilization review, whatever you want to label it, can't occur within those timeframes. It does not mean, by the way, that our providers should keep people who don't medically need that level of care. They should be moved. We created our own level of care tool to try to make it easier and to develop consistency. We make our providers use it. We make the insurers use it. And we believe in it, and it's working. So just a couple other points too, though. Leah was dead on. I'll give you the statistics. 60% of admissions to OASIS programs are not for opioid use disorder. 40% is about what comes in for opioid use disorder, where clearly medications are the first line of intervention. So there are many people we treat where there is no medication that's a proper intervention at all, or especially at the beginning. So we always need to keep context as we get obsessed and fall into the conversation about opioids specifically. Our system, alcohol has always been the #1 substance for admission to our treatment programs, and it likely, unfortunately, will be forever. Couple other points. Leah hit on some of the other kinds of things. So what I would put out to the payers in the room, the frontline interventions before treatment ever becomes the need. So screening, brief intervention for referral to treatment, easy access to medications, payment for the use of certified peers in our system. Do you consistently pay for those kinds of interventions that can occur way before more expensive bedded treatment is the need? So I would put out to everybody, as we think about the rating system and we think about all that's going on, we also think about things that we all could be doing to maybe help people avoid the need for expensive levels of treatment because we did other interventions before that ever was the need. So I think I have a lot more to say, but I'll stop at this point so others can chime in.
Well, that was great, Rob. Allegra, thoughts on Leah's presentation?
Yes, absolutely. So I'm Allegra Shore, representing COMPA, Coalition of Medication-Assisted Treatment Providers and Advocates. So we represent the opioid treatment programs, and we also represent OBOTs, so office-based treatment facilities. And so just basically, I think we really see this shatterproof rating system as an opportunity. Opioid treatment programs in particular, have a history of being siloed. So I think for our providers, we see this sort of in a continuum. Opioid treatment programs are the only, from a federally accredited, a requirement to be federally accredited. And just to put that in perspective, There were two inflection points that really brought that about. So this is the idea of quality, and quality ratings is really not new for us. In 1998, there was a study that came out that by Dr. John Ball that looked at reducing the risk of AIDS in methadone treatment programs. And the main point of that study was that the characteristics of the quality of treatment in the methadone treatment programs was more important to patient outcomes than the characteristic of the patient when they enter treatment. So if you think about that for a moment, what was happening in the treatment program, the quality of that treatment had a bigger impact on the patient than the severity of the patient in terms of their AIDS. So that really made an impact on the thinking of the federal government. And that was followed really in 1990, just 2 years later, by a general GAO report. I know in the news quite a bit of federal reports. This one was not redacted in any way, but the methadone maintenance, some treatment programs are not effective and require greater federal oversight. So you can imagine those two together. Basically at that point, the federal government then said FDA had been the federal oversight agency and SAMHSA then took over. So at that point, SAMHSA said, we want to see all OTPs accredited. So that's 1990. Here we are in 2019. We have all of our programs either Joint Commission or CARF, essentially. So this is quite a few years later. And why I say we really see this as an opportunity because all of our programs meet federal standards. So we really, and I think pretty much everybody knows, methadone in particular, if you go and try to see studies, there's tons of studies. So in terms of meeting standards and peer review, there's no question about the efficacy of our programs. What we have was the first thing that like I said, is stigma. So how do we meet that? And I think this is a real opportunity for us to really get out, to have patients and have families and have the public see what we're doing. And so for us, this is a really exciting opportunity.
Thanks, Allegra. Pam?
Good morning, everyone. I am from the Capital District Physician Health Plan. We're a small regional plan in upstate New York, serving just under 400,000 members in the Capital District. Maybe some of you in the room have our health plan. I want to thank Leah and Rob. We're very excited about participating in a pilot that looks at quality and ratings. And so as a health plan, one of the key things that we want to promote is access to evidence-based care. And in New York State, we're lucky to have a good partner with Oasis. I am relieved that the presentation included a segment on continuous quality improvement and really the importance of having technical assistance for our provider network. We certainly, as we move into value-based care, are very interested in how we can direct our members to the best quality care. We don't want them to leave the state. We want them to stay with our network providers. And we want to help our network adopt evidence-based. It usually, there's no quite fast track to adoption of new technologies and evidence-based medicine. And I think that requires assistance. And so I'm happy that Rob Kent talked about that. We don't want to put people out of business. We want to make sure, especially in some rural areas where there's only a limited number of providers, we want to ensure the success. So just certainly, in short, of course, as a health plan, we want to promote quality. We ourselves participate in quality performance. So, and I'm glad that Leah comes with background from NCQA. Our ratings are very important to us. So I would like to make sure that any rating system aligns with NCQA, HEDIS metrics, and the state, in New York State, the quality assurance reporting requirements are measures. And I guess time will tell whether, we want to, the 7 base consumer ratings to make sure that they're statistically significant. So I guess that's more conversation. And then as Rob pointed out, it's not, while we're in an epidemic, we still want to focus on addiction to any substance, including alcohol. And so the quality measures, perhaps they could be expanded to include those related to alcohol dependence. So I am going to turn the mic back to Eric.
All right, thanks again. John?
Good morning. I'm John Capola of the New York Association of Alcoholism and Substance Use Providers. I want to also thank Eric and Leah and staff at Shatterproof for this opportunity. I want to just make note in my initial remarks, in thinking about the health plans and the degree to which in the, let's say, the last 5 years, it's been necessary for them to hire some extraordinarily expert people who understand addiction and mental health. And that there's been I think a notable shift in as a consequence of that, in the relationships between the health plans and service providers, that there's a dialogue now that's very focused on quality and outcomes, and increasingly on collaboration. So I think the timing of the Shatterproof effort is really important. And I just want to comment for a moment on the importance. Once we've sort of finalized all of the measures and the metrics, and we start collecting data, what do we do with it? And so this whole idea of sort of weeding out the good programs, or weeding out the bad ones, as opposed to rising tide raises all boats. Like, how do we take the information that we're learning? How do we support what is a statewide system where there's not a lot of replication, there's not a lot of room for weeding out, there's a lot of room for strengthening. And so how do we go about doing that? And I think it's extraordinarily important to kind of contextualize this conversation just a little bit. It wasn't that long ago that Dr. Alan Leshner at NIDA was putting up on the screen, PET scan, x-rays of the brain, and say we've now identified, that this is a brain disease. And for those of us who've been in the field for more than 15 or 20 years, we remember the heated debates about whether addiction was a disease or not, and where people sort of just dug their heels in, it's not a disease, it's character, et cetera, right? There were very few medications. There was very little technology, if any. And on every turn, as science has, and you get a sense from this project how quickly it's moving, right? Why? Well, because it's extraordinarily important. There's resources behind it. It's right, the timing is right, and we don't want to lose any more ground. But I think it's extraordinarily important that as we move forward, that we're extraordinarily mindful of using the data to strengthen, the existing continuum of services. So that for folks who had not had any knowledge about medications because they weren't there, many of them, I think, Allegra talking about methadone. Methadone was the first major medication that was, on the scene. There were some initially for alcohol as well. But we're in a much different, we all have heard the phrase medication-assisted recovery, medication-assisted treatment. And, that's just part of it. When we start thinking about data and collecting data and developing value statements for our organizations and entering into really good conversations with health plans and with the state of New York about how to strengthen our programs, what is the data infrastructure that we have in our systems? What are we collecting the data with? And again, this Shatterproof initiative is going to, I think, really help a lot with that. So I think as we enter this idea of monitoring our programs, giving, and I think all of the parties, and I think Shatterproof is to be praised for this, they have engaged national experts. They have given us the opportunity to participate in this pilot, and I think to echo Rob's sentiment, if we had been given the opportunity to volunteer to do this, and we did a letter of support, we think it's a great idea that New York is part of this pilot, and we appreciate the fact that Shatterproof has been very open to feedback that we've had up until this point. So I guess I want to just conclude by saying we have a huge opportunity at this point to really collaborate across all of the sectors with Oasis, with service providers, with payers, consumers, and family members. And they've all been involved in this process up until this point. And that we really, I think, have to commit ourselves to each other that this is fundamentally about strengthening the services that we offer in this state so that when families go to the website, they have a multitude of options. And have some confidence, that we've all worked. And I think one of the things that we will discover is that to some extent, there are parts of the state and parts of the field that are significantly under-resourced, whether it be about technology, whether it be about service delivery. And I think as we identify that data, we can collaborate together to make sure that Oasis has the resources it needs to, have a 4 or 5-star system. Thank you.
Senator?
Hi, thank you for having me here, and I was carefully testing a joke before coming up here, so I'm gonna go ahead. I think it went pretty well. When we have these meetings, I think about 90% of the content can be probably replaced by trust exercises, but then I think the 10% really needs to be substantiated by transparent and open rating scales. So I think this is a really good place to be, and thanks for giving us the opportunity. I represent WellCare. WellCare is a national plan, one of the 10 plans that are signatories to the National Principles of Care by Shatterproof. So this is really exciting. We've been working on this for the last 2 years in different ways. Some of the folks at the state may recognize that our telehealth improvement plan was actually taking the 10 principles of care and superimposing what we needed to do for telehealth, really to emphasize the point that it's about disease management. It's about universal principles of care. If you were thinking about creating a system for treatment of diabetes or asthma, these principles of care will work just as well. So this kind of consistency is extremely important when we think in terms of system redesign and how do we really click things together in a way that we have meaningful continuity. And this is the other part that we've had a chance to discuss with Leah when we started talking a little while ago. How do we think about social determinants really factoring into this? Because you can have the best, most wonderful, well-meaning providers, but if there is no recovery community to enter in after you receive the services, you will struggle. That kind of information is incredibly important, both to the municipalities and the state, but also to the providers themselves. They cannot and should not be held accountable for things that they cannot control meaningfully, and that but is if you know your community struggles with effective resources. This kind of data can provide you with meaningful opportunity to change the way the system works. Rob mentioned Google searches. I would love to imagine a near future where Google searches are populated by Shatterproof ratings, where we can think in terms of red, yellow, and green lights when you know when you're in a particular community, where you're going, what are the best outcomes that are connected to your care. So all of that to say is, I think from the seat at the table, from the plan's perspectives, having these kinds of efforts and these kinds of systems, it's just incredibly helpful and incredibly welcomed. And we really hope to steal and borrow, as I was also mentioning, that New York is so far ahead of so many other states This gives such a great opportunity, and I really want to emphasize that the work that New York providers and HPA is doing is something that will have ramifications well beyond New York's borders, and we can really impact the system of care nationally. So thanks for everyone's work.
So thank you all. I wanted to pick up on a point that Ann had made, maybe you start with Ann and then open it up to the rest of the panel. And you had talked about, or made comment to, there's no fast track to new evidence, but I was curious as to how you see really the work of shatterproof measurement being able to introduce or at least provide information on new approaches, new treatment options, changes to guidelines, and really want to sort of start with you and maybe open it up for others on the panel to speak to that.
One of the, I had worked in a hospital network doing addiction medicine, and I think in medicine in general, people are in practice and they get comfortable, and when new things come along, it can be a little bit of a hurdle to adopt new practice. Sometimes people need incentives to change, and whole systems need incentives. When you're looking at yourself as you relate to your peers, usually physicians and other health organizations don't want to be the outlier that's not providing quality care. And having the transparency or even a tool to work with does motivate people. How do you get people to change? I don't think it's always about money. Many providers, that might be something. Obviously, we want to make sure that people can sustain their practice. I don't know if I'm answering your question, but certainly I think that when you have a rating system and you can see areas for improvement and have a real performance improvement plan in place, we can all work together to rise all the boats.
Thoughts from others on that point?
Yeah, I think sort of bringing back to the, you said, improvement plans and quality improvement and those plans. One of the plus and minus, or the pros and cons of a rating system is allowing the opportunity for innovation. And where do you try something new? For instance, genetic testing may be a sort of an idea. Do we incentivize those kind of something that's a little more cutting edge? Could be something that's really beneficial, not something that's in any standard at the moment. I mean, it's certainly, but clearly has lots of potential. So that would certainly be an outliner, from what we have right now. Do we test that out? Do we put that in performance improvement? Do we then, come back and do that as a project? In accreditation models, there's room to do those kinds of things. Similarly, if we have a problem, in an accreditation model, we don't come back, as Rob had said, punitively. So we have to make sure that there's room for error and not in a way that, that we allow growth and we allow opportunities to make sure that there's a trial and error process.
So having spent appreciable amount of time with the Shatterproof's rating system, I have to say it's really quite comprehensive and quite great. It does have limitations. And one of the limitations is relevant to this question, and that it, by necessity, based on available data, it focuses still on a great deal of process measures rather than outcome measures. And genetic testing, great example. So we can focus on the process measure. Let's start paying for it. Let's think in terms of who can do it and how much we pay for it. Or we can look at the data. And the data, unfortunately, is going to be a lot less rosy, where there was an article in Psychiatric News just last week about the fact that genetic testing for mental health and substance use disorders is just not ready for prime time. So do we ride ahead and create those shortcuts and get to the processes that we hope will work versus think about data and think about what are the best practices, what we know will work? There's always a tension. But until and unless you start trying and start measuring and start creating pilots, you're not going to get there. So I think having these kinds of rating systems really helps to get this right.
If I could just add a little bit, one of the things that'll be really interesting is that we start with this rating system and we ask ourselves additional questions. So it's not inconceivable that we could have a program which might be coming up a little bit short on a specific rating, and then when we examine the degree to which that program is actually helping to improve population health in a manner that's outside of the measure, A, or B, driving significant savings by sort of diverting somebody from a more costly or unnecessary medical intervention to something which is less costly and more effective. So I think what we want to make sure that we do is to ensure that our conversations go beyond just these specific measures and are constantly interacting with each other to find creative ways of conceptualizing what we're actually doing.
I just want to point out, we've been joined by Assembly Member Linda Rosenthal, Chair of the Assembly's Committee. We appreciate you taking the time to be with us today. Assemblywoman, I don't know if you've had, I know you just got here, but much of the conversation is focused on, obviously, the rating system and then sort of how it's going to be implemented. I don't know, if you have any initial thoughts before we continue with the conversation.
No, I don't, but go ahead, and thanks for having me. Sorry I was late, I have to leave a little early. We have committee meetings, etc.
Busy session day, we know, so
Yes.
we appreciate you tagging in.
Thanks for having me.
So let me pick up on sort of the point that was made about sort of future state. And Leah, you guys have done a tremendous amount of work and still have more work to do before this gets rolled out next year. And we're already hearing folks think about what the future state might look like. Can you talk a little bit about how sort of engagement will work, and as new measures maybe get added or removed, what the thought process is there?
Yeah, absolutely. Well, I think that Sander and John really hit the nail on the head, and that this is very process and structure focused at this point. I think we're really focused on building an infrastructure that will sustain continuous quality improvement. The end goal is ultimately to get to outcomes, but we need to have a starting point. It will be an iterative process, and I think with any quality improvement effort, you look and establish a baseline, and we identify opportunities. In coming years, after year one, I think that we'll continue to look at the measures being used. We'll refine those, add new measures. There are not a lot of outcome measures in this space right now. There are quite a few that are under development, but I think this is definitely about a starting point and learning from the data that we get. There are a lot of unknowns just because this hasn't been done before, and I think that's kind of where we stand.
Yeah, and how will the other pilots going on in the other 4 states, how will that get incorporated into this? And I imagine other states are going to want to maybe steal from New York a bit.
Absolutely. Yeah, so we have our first all-state call coming up in June. We'll be bringing all the state agencies together to talk about what they've learned so far, where they see opportunities, and where the challenges have been in provider engagement and kind of getting the word out there about this project. But I think we see the opportunity to keep to have the states collaborate. I think there is already a level of copying. States are curious how other states are approaching this, and especially when you talk about incentives. And encouraging providers to report to the rating system, as not all states will be requiring that. And I think there's definitely a dialogue going on between the states about how to best promote that.
Go ahead.
Okay.
I just wanted to point out that the Office of Mental Health, as part of the working with DOH, the QUAR measures, has started to introduce measures that we measure or try to measure outcomes as they relate to social determinants of health. So they include things such as completion of higher education, employment, housing, interaction with the justice system. So I think, New York State, we can even lend to this pilot with some of the good work that's being done.
I wanted to pick up on a point, a great point that John had made earlier, sort of the question of what do we do with the data and how do we utilize this data to strengthen the continuum of services? John, I'm starting with John and then maybe others can jump in here, is, based on that question, what would you envision or how would you like to see sort of that used to, the thing we've heard, sort of lift all boats or strengthen those that may need some additional help?
Well, I think we start with the assumption that every program is interested in becoming better and better, and is interested in offering a comprehensive continuum of services that's evidence-based. And then I think we look at the infrastructure across the state. To what extent do we have an environment where we have learning communities, where we have programs that are meeting with some level of regularity, not as competitors, but as partners in the region, working closely with Oasis to identify, how do we kind of combine our, sort of capacity and ensure that in our part of the state that families and individuals have access to everything that they need. So it's really, I think, and I think Rob hit the bullseye, in saying that it wouldn't be punitive. It's seen as, where are the gaps? And then making the assumption we're all going to work on this together. It's in everybody's interest that we get this right. So I think it's really about those learning communities, that collaborative culture that we have to create together.
I just, a couple points. So, understand the landscape we're in. So nationally, right, the Surgeon General 2016, about 1 out of every 10 people in need of addiction treatment specialty services can actually get it or gets it. New York, we're a little bit better. I think we're like 2.5 out of every 10. So we're better. But still, there's 7 people we're missing, right? 8 people we're missing. So the way we view the rating system and this work, it fits into a much bigger initiative, and it will help us identify the things that matter and that we're going to look to see that providers are doing. And it influences payers, it influences consumers, and it helps us drive policy change that we're trying to make. And we think all of that needs to happen, but again, we need to start somewhere. So I get, the beauty in life, right, is when you put something out there that's big and bold, everyone will tell you how and why you can't do it. And then you can either say, okay, or you can just say, well, we'll figure it out as we do it, which is sort of what we do in New York. But again, at the end of the day, what we can't ignore is that people in need of help will use things like this to decide where to go get help, and they will drive markets. They will help, as we try to drive policy change and make sure all our providers are making medication-assisted treatment available, which is a requirement, to be clear, in the law, in our rules. We expect every Oasis provider to make that possible. Now, what they all need to be thinking about is, do they do it, is everybody buy one of everything, or do they partner up? I was talking to Rose Duhan earlier, Chickani's FQHCs, we're pushing collectively, work together. You're serving the same people. Why do you both need to be each other's, business? You don't. And again, we're trying to use the rating system as part of a bigger overall strategy to drive better performance, to drive the key things that need to be going on in our system to be going on. And at the end of the day, what a system does that's open and transparent, it puts it out there for people to make their own decisions about what's best for them. And that drives what goes on in the world. Providers, we won't punish providers because they're not doing things. To be honest, we won't need to. The marketplace will take care of that. So we need to be open to those kinds of things. But the interesting thing is with the opioid epidemic, it's pulled the curtain up on our system, which is good, and sometimes maybe not so good. But we have to be thinking and doing things differently because we're losing tens of thousands of Americans every year because we don't. So, and I'm not trying to castigate him. Our system is great. I believe in our system. We are ahead of everybody, I think, in the country. But there's work to be done. We can't be okay with serving 2 out of 10 people. Because we pay for it, by the way, Eric, as your members would know. They show up in EDs, they show up in all the most expensive places, or they show up in morgues, neither of which is okay. So this fits within a bigger overall strategy of trying to make things better for people who live in this state.
I'd like to add something. I've been chair of this committee maybe 4 years or so, and one thing I am is impatient. And I think you have to have some of that impatience or also patience to be here in the legislature, impatient with the lack of progress on so many fronts, but patient knowing that government often works slowly. However, people have been saying we're in the midst of an opioid crisis for how long? It's been years. And everyone uses it as a talking point. Yes, we have a horrible opioid crisis. And I've heard from so many people, treatment providers, people who suffer from substance use disorder, and they regale me, maybe that's the wrong word, with a litany of things that are wrong. They can't find a doctor to prescribe, any buprenorphine, etc. They can't afford the copays. They're in the emergency room after an overdose and they are, dismissed. No naloxone, no buprenorphine, no anything. We know where many of the problems are, so I think this system that you're working on is great, but not just anecdotally, empirically, we know, and you can ask any treatment provider, where are the gaps, what are the problems, and here's where my impatience comes in, is, I have to fight to get legislation passed about no copays. Every time someone goes and gets methadone, they have to pay a copay. What kind of ridiculousness is this? Also prior authorizations. And as Rob said, we know MAT works, but it's taken a while to convince some out there that that's the right way to go. So I'm impatient with just citing statistics over and over, which people do, and out there, and then nothing happens. And we need more funding dedicated to this. We have such an engaged and dedicated group of activists and advocates, and sometimes it feels to me like we're shouting into the darkness. And so we really have to, we really have to pump up what we're doing in New York State, and we have to do it quickly because people are dying. I mean, one program that I'm in favor of, I've introduced the bill on, that's very controversial but has worked around the world, is opioid overdose centers, as they're now called. They were called safe injection sites, they're other names. But that basically the idea is, and it's been in Switzerland for decades, it's in Vancouver, it's all around the world. People who use go to these places, which are mostly cited in the same places, syringe exchange programs or other kind of programs, where they use their pre-obtained drug, they test it for if there's fentanyl in it. There are medical professionals on site to ensure they do not die. And that doesn't happen when someone's in McDonald's or in the local park. I mean, the bottom line is we want to keep people alive. And yet there is tremendous resistance to this. People don't want it cited near them, even though their whole community is afflicted with this problem. There's resistance on all levels of government. And I think it's shameful. I mean, we can study it, but it's been out there for decades and it works all around the world. And we can't get it done here. So, that's another frustrating thing, something I'm impatient about. I know now with the specter of Mr. Orange, and that's a compliment, in the White House, I could say a lot worse. Governments are afraid, but I think we have to be bold during this epidemic. We have to try, we have to challenge ourselves to cut down on the number of people who die and the number of people who are increasingly becoming addicted to substances. Thanks.
I just wanted to pick up on something that you just mentioned, the safe injection sites. Just thinking of the opportunity of having people there being safe, but also providing care right there in real time. This is something that we wrote in the Hep C task force, where you have an opportunity to really render care where people are when they are most vulnerable, but may be actually willing to and able to really engage and be part of the system of care. So there are some things that we still can do, and having transparent ratings really helps. But there's always the need for additional funding. Now, the money doesn't come from nowhere, but there is money that is to be had if we figure out the way to use rating systems as a path to getting to that money. Imagine if we think in terms of the existing VBP roadmap and think about if you have providers that are engaging in value-based contracts that focus on substance use treatment, suicide care, and we give additional weight to those contracts in the VBP roadmap. That's the money that is already being spent, being allocated, but we can raise the awareness and raise the need for thinking in terms of impact that substance use treatment has on total cost of care. Because the simple reality is that plans are very much aligned with that very basic aspect. When we invest in taking opioid crisis in particular, when we invest in buprenorphine, when we increase access to buprenorphine, and hopefully we can have telehealth enabling that as well, we in fact save money for the system. Dollars and cents are quite clear. So, for example, WellCare has now been going to state governments in other states where we are looking at the data from New York and advocating, instilling the same kind of mandates on equal access and removing pre-authorization, because once all plans are doing it, it really spreads the cost and allows the systems to change. So these things do have to start from transparency and go on into contracts that can in fact enable effective work being done in communities.
Go ahead.
One thing just going, really focusing on the effectiveness of the rating system, the two issues for our providers that we want to focus on and make sure that it's really working at its peak, would be the making sure, and this is really, when you think about rating systems, and I think this is really sort of always the issue, is figuring the severity. So it would be true, I think, of addiction services. Same thing I would guess is true of cardiology. It's the perennial problem, right? How do we make sure that the providers that are seeing the most severe patients how is that counted for? And that's really something that, I don't think, and I know Leigh and I have discussed this, so that's something we really want to make sure that we're handling really well. That's, I think, really still yet to be worked out, but clearly must be to really be effective. And the other issue is the sort of more objective, subjective piece, and making sure, actually, I think for our providers, to really keep that always separate, so that if you're looking at that there's, that it's always very, very clear that the customer rating piece is a customer rating piece. And then the other pieces are a more objective piece. Because to give just sort of 1 star or 2 stars or something, that somehow if those have been sort of blended together, it would be, I think, very difficult, because, there's so much emotion in our system, and for a consumer, to sort of blend those, I think, would be something that we'd be concerned about.
Go ahead. Yeah, sure.
I just wanted to respond to that. So over the past few months, we've done a great deal of engagement with providers. I know Allegra and I have talked about this, and Rob, and we've talked with folks at Oasis about what the rating will actually look like and how we're integrating those three data sources. Being really sensitive to the fact that we don't want to penalize providers and that there are so many confounding factors when you're dealing with programs that might have a much higher acuity population that are very, very complicated. So we recently determined that we will not be using a composite score. So the rating will not have a star or number in this first phase. But the different pieces of information, those different principles of care like access and MAT, and that data will be shared. But it's just, we decided it's not in the, it's just not in a place where it's ready for prime time, and we want to make sure that we're hearing providers, and I think that we'll continue to do that. This week we have our first, we formed a New York State Advisory Committee, which will pull together both providers and payers. We also have some great consumer advocates on that, and then folks from the state. And so I think that we're really hearing that feedback, and we want to make sure we build something that works and that's fair. So thank you for bringing that up, Allegra.
I just want to say too, that's actually a really good example because, like, again, part of why New York asked to be part of this is exactly this reason. We're influencing the development of what is going to happen, right? And versus sitting on the sidelines and seeing something at the back end where you may have had no input. So I just want to publicly thank Leah and Shatterproof because they have delivered on what they promised, that if we did participate, it would be an open process. They were, open and willing to make adjustments, and that is indeed the case. And again, there are plenty of reasons why everyone will be skeptical or concerned, but I have more concern with doing nothing.
So I wanted to pick up on an earlier point from the Assembly member. As chair of the Committee on Alcoholism and Drug Abuse, can you give us just sort of your perspective on how you might envision the work that Shatterproof and the state's doing around this rating system being incorporated into potential policy proposals?
Well, certainly you guys are the experts. And I think, once you've come up with, when your project is done, we could have roundtables to educate legislators, both Senate and Assembly, and policymakers who are not involved, to discuss the best way that government can help implement your suggestions. We hear, as I said earlier, we hear a lot from providers and patients, et cetera, but if you're gonna formulate how we go about dealing with this crisis, I think that kind of thing would be the best. Yeah, thank you. And I'd be happy to, once you're ready, to organize those with you.
We'll take you up on that.
Okay, and also, not just do it in Albany, we can do it around the state. So people also feel that, the experts, the scientists, the physicians, the treatment providers are listening to them and understand what they go through, and also getting feedback from them in different communities. Because, you hear, in X city upstate, we have no one who will prescribe whatever for us. And then you can come and say, here's what we've learned, here's what we think we should do going forward, and, have a dialogue with people who are directly affected by this.
So picking up on an earlier point about other measures, and I know Sandra and others have talked about social determinants and genetic testing, I want to sort of put it out there to both Ann and Sandra as well as Allegra and John. Are there particular measures right now that aren't part of the measurement process, but perhaps down the road you'd envision wanting to see those as included as part of sort of the future state of a rating system.
I know our focus today is opioid use disorder, but I really would like to lobby for other measures that relate to alcohol use disorder and continuity of care. And then there is a measure when people leave treatment, maybe we can capture those who leave against medical advice.
Well, I think one of the complaints that we often field with providers is the sense that different payers ask for different things and different measures. And so much of that is driven by perception, because we in fact are all chasing the same measures. But year to year, when we're doing poorly in one, we may be putting more emphasis on one. And then that switches next year and next year. So bringing consistency to measures, so things that we are looking for in CORE for New York State should be consistent with the things that we're looking in Shatterproof. And that could really help to ease the burden on providers and frankly the payers. If we're all focusing on the same set, with the same transparency, with the same availability of this, the way the CORE outcome measures are available on the state's website, imagine the same place where we can look at Shatterproof ratings and have providers and payers rated and focused on the same measure sets. That consistency, I think, would be really helpful from our perspective.
I want to emphasize that too, that if we align our goals, you'll get more participation.
If I could just suggest that when we look at social determinants, when we look at some of the natural consequences of somebody who starts to address their substance use disorder, lots of good things happen. And I would suggest that as we begin to work with Shatterproof on this rating scale, when we convene and when we start analyzing, like, what are we learning and what are we seeing, this question about what are we not capturing, right? Because one of the things that'll probably happen for some programs is they're not going to be happy with their scores. And they're going to be a little bit dismayed that this wonderful work they're doing is somehow not manifesting itself in a good grade, for lack of better words. And there are so many other measures that they're using internally, and loosely using the word measures. They're aware of outcomes in their program that are significant. A very concrete example was in a program yesterday that does some supportive housing. And they had all this data about the children in their family supportive housing, had all this data about the educational achievements of the children living in the housing. And they looked at it from the standpoint of children in elementary school, children in middle school, and children in high school. And the grades got dramatically better as time went on. And so, this program could easily say, because of what we're doing with these families, it's not coincidence, look at this remarkable outcome. Now they're not getting paid to do that, right? They're not getting paid to do that. And similarly, when we look at Medicaid data and we start realizing that people are much more compliant with their medications on diabetes or heart disease or whatever else their other health conditions might be, when we start looking at those measures. So again, I think there's an opportunity here and just one final point is that many of our programs were giving themselves like an F on as a grade because somebody left before they were completely void of any drug or alcohol use, right? This is considered a failure. If somebody comes in and so the concept of harm reduction in our programs is still relatively new. And I would hope that as we're looking at these measures, that we're able to incorporate that and help programs to understand that making significant progress with drug or alcohol use is something that's good. And if somebody is moving in a healthier direction while they're in your care, that's a good thing. And we don't have to just measure by some predetermined outcome that we want everybody to gain. That's just, those days I think are gone, but it's gonna take some time.
I wonder if I could ask a question. I'm just thinking about how all of this can't be taken in a vacuum. So the intersection of poverty and abuse, domestic abuse, child abuse, racism, housing. So I'm sure all of those issues will factor in to this. How could the outcomes of this project be coordinated with or discussed with experts in those areas? Like housing, you can be fine and you're evicted. What's going to happen to you? You know, we know what's going to happen most probably. So how can we use the data that is accumulated and discovered here to help influence in those other areas of people's lives?
I think one of the things I was thinking, and this may be a somewhat New York-centric idea, but some indication of, I mean, we talked, one of the measures is the care coordination if you're not fully integrated, but very few substance use providers are fully integrated in terms of social determinants. So are you part of a BHCC? Are you part of, because just saying, yeah, we do care coordination isn't really an answer. How are you going to do that if you're not actually part of a larger organization? How can you possibly if you are just some sort of standalone? So it seems to me that that one of the measures is some indication that you belong to some larger care collaboration, because that would really indicate that you have the means to actually do the care coordination in an effective way. So to me, that's a measure that would really be meaningful.
I wanted to chime in. I think what we are all, in a way, talking about is the long runway for a lot of these benefits that accrue over time. And we are trying to imagine where the world where we have the, and I'm going to go back to value-based purchasing, that really gives us that opportunity to think in terms of total cost of care, which we're talking about illness care, right? We're talking about immediacy of that healthcare, but the benefits, as John is pointing out, may accrue years later. So do we have the right tools to think in terms of aggregating these value-based contracts and these value-based arrangements and distributing the accrued savings to the right people, even despite, for example, when we look at New York State Medicaid, where we have very significant churn between members moving from plan to plan. Do we have the opportunity of thinking about lock-in periods that allow some of those savings to materialize for the entities that make the investment? Or do we think in terms of enabling a system where the long-term outcomes driving long-term savings can pass through back to the payers, back to the providers? Because if you think about, we have two, and I'm specifically talking about New York State Medicaid. We have the MCOs, medical, so you have the insurers that are integrated, that do all health, medical, and behavioral health and substance use, and those that delegate to BHOs, behavioral health organizations like Beacon, Magellan, Optum. So do we give enough of an opportunity for the accrued savings that largely are on the medical side to pass on back to BHO to be passed on to providers? Is that structurally designed in the current Medicaid rules that allow for that pass-through to really be meaningfully penetrating back to the communities?
I think this also brings up, you're talking about social determinants of health, and managed care companies do recognize that we need to address them. So for example, when we look at utilization of emergency rooms or inpatient services, if we don't address the housing problem, then the person will end up back in the emergency room, which it's sometimes very hard for managed care companies to coordinate with state agencies. There's an overall shortage of housing programs, but that is something to consider. In other states, managed care companies also manage the monies from the local municipalities or the state to also coordinate the housing programs. So I know at one point there was talk about OMH having managed care companies do the housing subsidy, and that's sort of been, like, no one's talking about it right now, but that's a future thing. We might have to coordinate with you on how we might, for example, foster care agencies, that we might have a greater role.
Just a suggestion, and this is for Shatterproof and then down the road, that as we look at outcomes, and we really, I think Sandra's point about, if we just think about the health plans that delegate their behavioral health to these behavioral health managed care companies, it's almost incomprehensible that there wouldn't be a boardroom discussion at a health plan about how much savings are we driving from our behavioral health work in the other sector. And then how can we incentivize an investment and strengthen that behavioral health work to drive even more savings. And the idea of creating profit by doing that would seem to be somewhat appealing. The idea of reinvesting is equally appealing, and the same conversation happens in state government, where you have a behavioral health agency working with a system which is engaging more people in care and at the same time driving up the amount of Medicaid dollars that are spent. But we haven't taken the time to examine, where is there savings that occurs elsewhere, and why aren't we investing, more of those dollars? So that's a discussion that absolutely should be a part of our dialogue, particularly as Leah mentioned, that resources is one of the things that they're going to be looking at, and I think that if there are resources anywhere, if we're correct, that there will be resources generated by savings that are created elsewhere outside of the behavioral health arena.
Yeah, so on this whole point of investment in resources, so this is Rob Kent saying this. So there is money already within us that is not spent in the right ways. So when I say that, I say to the insurers, I think you spend a lot of money on staff, on process related to access and continuity of care and that maybe could be better spent on some of these other things. To our providers, so on equal opportunity, I believe some of our providers spend money on staff addressing the fiction of our rules versus the reality of our rules. So I think even within that which we already have, there's opportunity. What I've always viewed the best role, managed care is at its best when it's doing front-end prevention work and when it's working with us and our providers to make sure there's real meaningful connections and continuity. Because the beauty of managed care is while you have to pay for the things we mandate, you're free to do other things that we don't mandate, like buying housing, like investing in peers and having peers involved in this process. So I believe, and I hope one of the conversations we have, and we'll use Shatterproof's rating system to crystallize these kinds of things, but I think there's an enormous opportunity for us to have this bigger conversation about what is it we all do with each other, how could we do it better, and how could we take money that I believe is already there and invest it into things we all agree will ultimately get people better care, get them healthier, have them using their health services in a more regular way versus in an acute, abrupt way. So I think there's an enormous opportunity. I travel all over the state. I'll go wherever you want me to go. and we'll have these kinds of conversations, because I think it's worth it.
So we're almost up against 10 o'clock. Before we wrap up, I just wanted to see if there were any questions from the audience. Oh, go ahead.
It's more of a comment. This is really exciting for existing providers. I work for a managed Medicaid plan in Western New York, and I'm really hopeful that you guys identify lack of providers in the area and maybe come up with a way to give incentives as you're talking to draw some providers. I think if you're using Locator as a resource, you're not going to find any IOP programs for individuals with substance abuse issues. So identifying some needs and gaps in care is really what my hope would be, and to point out the providers who are doing a lot of good work in the area. To your point, Rob, Western New York has really found value in reinvesting in boots on the ground. Social determinants is a huge issue for us, and we have people in the hospitals and all over, and we invest in that regularly. So I agree. So now bring the providers to Western New York. But thank you, this is exciting.
You know, just one point to that too, though, we have a work group that we've had going, since 2014? And it was supposed to end with a report, it continues, Sanders on it, and we have stakeholders from our providers, from most of the medical directors, from managed care plans, family advocates. We continue it because it is producing those kinds of conversations where we're talking about resources that insurers want to buy in their marketplace that doesn't exist, and they're saying it to the providers from their marketplace. I invite any of you to come to those meetings. We've continued them because we are finding value. Ann's on it as well. And to be clear, the building a little ways up is where you can all fight with each other, and that's not the room where we fight with each other. We talk about ways we can work together. We'd love to take it on the road, expand it, because I do think everyone is interested in trying to help people. I don't believe anybody, or maybe there's a few, but most people want to do the right thing. You think we don't necessarily get into the same rooms and have those real honest conversations with each other. I think, we would, again, to try to tie it back to Leah, the shatterproof, this system will help us, I think, sort of crystallize on what should matter, what matters, what we all should be looking at. It'll drive behavior change, but I still believe that there's a huge opportunity for us to talk about ways we could work with each other in a better way.
I think on that note, this is going to be probably the first of many, conversations that we're going to be having. I think one of the takeaways from today is, let's see if we can sort of take this on the road over the next few months. I know Senator Harkin had mentioned a series of forums as well. So I think, in addition to that, one of the other big takeaways is it sounds like, there is a recognition that measurement is going to be really important for us to be able, as a tool in the toolbox, to address the opioid crisis, in addition to many other steps they're taking. So please join me in thanking the panel today for joining us. Thank you all for coming. We will be sending out a short survey to folks in the next couple of days. We'd love your feedback on today's forum and any other ideas you have for future forums. Surveys help us in developing our programs. In the meantime, it's a very busy session day, so thank you again for coming and enjoy the rest of your week.